Welcome to the first annual Symposium on Mitochondrial Health, Healthspan, and Aging. Exercise and nutritional interventions are the only proven strategies to extend human health span and lifespan.
My name is Mark Tarnopolsky. I just had a kind introduction, and I would like to thank Bob Navio and Sandeep for the kind introduction to speak here today. So before I start, I need to disclose several things. I've worked with several companies that are involved in treatment of Pompe disease and other lysosomal storage disorders, as well as mitochondrial disease. But most importantly, I will be talking about research which has formed the basis for a company that I started called Exerkine. Probably 90% of what I'm presenting today was before we started the company, but just in full disclosure from a conflict of interest, about 10% is after we started the company based on the research that I'm going to show you today. So I'll go through several topics. The first is lifespan versus healthspan versus disability threshold. I just want to define those terms because we really haven't talked about that yet. I'm going to go through some of the driving principles that has really driven me as a clinician scientist in my thoughts as to how we treat patients with mitochondrial disease, aging, and we'll be talking about obesity, and we've heard quite a bit about that today. And a few driving principles for me. Evolution is always smarter than human intelligence or artificial intelligence. That's point one. Number two, I've been a big proponent that multi-ingredient supplements will always outperform single ingredients. Sorry, Big Pharma, I know you've been stuck on single molecules for the last 50 years, but I don't think that's the best approach, especially for these complicated disorders that we're going to talk about. I'm going to then move to obesity and low muscle mass as influencers of health span and lifespan. And then I'm going to focus in on exercise and life/health span, and then talk about my 35 years of research experience in these areas, trying to improve muscle function and mitochondria, and you'll see in a minute why I've been so interested in these. But we're going to focus today on sarcopenia and aging and obesity for obvious reasons. So first, lifespan, health span, and disability threshold. Well, it's easy. Lifespan, it's your maximal length of life. Health span is the time that you spend in absence of disease. And this is interesting. I just read a paper up here in JAMA Network, and the one country in the world that has the longest gap is what? United States of America. Every country they looked at, they have the longest gap between health span and lifespan in the United States. And when you look at what influences health span, it's things that we're going to talk about today. Things like musculoskeletal disorders. In that, mainly that's osteoarthritis, which is negatively impacted when one is sedentary. We've actually done studies as well in people with osteoarthritis that the mitochondrial dysfunction is profound, almost a 20-year worsening of mitochondrial function in those who are getting total joint replacement, and other things like mental and substance use disorders, and a variety of things here which I won't get into and get down in the weeds, and let's get to the important stuff. So disability threshold, this is a very important concept in our neuromuscular patients, and that is that when people start to get weak, so let's look here at an individual, for example, who has muscular dystrophy, in this case, myotonic muscular dystrophy type 1. Their disease is causing progressive weakness. The metric that we're looking at is strength, and there's many other metrics, but in our clinic, knee strength is strongly correlated with disability. And as your knee strength goes down, you eventually cross a disability threshold. And we published in this paper here in myotonic dystrophy patients that when your knee extension strength on a biodex gets below 30 Newton meters, you have about a 50% chance of needing a cane. And when you get down below 10 meters, Newton meters, I should say, you have a 50% chance of needing wheelchair use, which increases healthcare costs. A motorized wheelchair in Canada is about $38,000, and when this happens to healthy individuals who are aging, and you'll see why those who are sedentary are going to cross these disability thresholds sooner than those who are active. As I look at my mother-in-law who's 94, clearly once you start breaking hips, once you become sarcopenic, and I'll explain that term in just a minute, you end up requiring institutionalization, which I'm sure all of us are familiar with older grandparents. So what are some other themes that are going to resonate throughout my talk and things that have really driven me in my career? One is mitochondria, and that's why we're here today. And if we think about eukaryotic cells, a big step in evolution from LUCA, the last universal common ancestor, as we've formed eukaryotic cells, I should say, this really interesting symbiotic relationship occurred about 2 billion years ago, where the mitochondria, which was a bacteria, entered our cell, and we heard earlier that we lost most of the control of making mitochondria to the nuclear genome. Another interesting evolutionary concept, which is something that gets to some of the protein supplements that we've used, is the mammalian split from birds and reptiles, which happened about 220 million years ago. And it's interesting that milk has the highest biological value, and it's equivalent to one other thing, which is egg whites. And that's when we split. And there's probably a reason why mothers feed babies breast milk, and there's something unique about that. And in fact, Stu Phillips, one of my first postdocs, and I have done some work on looking at the two main proteins. So the human ratio, the human milk ratio, is 60% whey, 40% casein. What's interesting is whey comes into our system very rapidly and turns on protein synthesis, and the casein clots in your stomach, comes in more slowly, and it attenuates protein degradation. So interestingly, Mother Nature just knew that this is the best way to grow muscle. And what's interesting is that it's different than cows. So if you look at cows, those of you who drink milk, go down to the store, it's 20% whey, 80% casein. And you might say, well, so what? You actually get a much better increase in muscle protein synthesis net with the human ratio. But interestingly, I came across a paper that showed that looking at human milk ratio to cow, you get a much higher peak in GLP-1 and GIP. And as you know, and we're going to talk about this, Ozempic, right? GLP-1 receptor agonist and the dual agonist by Lilly. The other thing that I've been really interested in my entire career and spent the last 50 years doing this, and that is running. So Homo sapiens were thought to have evolved probably between 280 and 300,000 years ago, somewhere in North-South Africa, and then we evolved and came through out of Africa hypothesis. And there is strong evidence that the ability to do endurance exercise helped to allow biological fitness to actually allow humans to survive. And if you look at my Vizsla, which is probably the best running dog in the world, I can outrun my Vizsla if it's 35 degrees or so in the summer. And humans did evolve to be able to do endurance exercise. And Bruce Springsteen, I think, put it best, baby, we were born to run. The other concept that's driven is, we're the ultimate omnivores. Part of the reason why we're so successful is we don't just eat, figs or nuts or something. We could eat a variety of substances. And what we eat are complex foods, not drugs. So think about coffee, for example. The link between coffee and cardiovascular disease, the link between coffee and a lower risk of diabetes, is consuming the entire coffee bean extract, which contains many complex molecules. But if you took a reductionist approach as a pharma company, you would say, it's caffeine. But if you infuse pure caffeine into a human, you induce insulin resistance. So I'm a big fan of complex molecules, multi-ingredient supplements. So what gives us power? Of course, mitochondria. And what's driven my career? So I started off actually wanting to be a phys ed teacher and was in biology and exercise physiology and started an exercise physiology group where what we did is we looked at the complex molecular adaptations which occur when someone does weight training to get hypertrophy or endurance training to get mitochondrial biogenesis. But then when I switched to becoming a neurologist, I saw patients who had atrophy, like Duchenne muscular dystrophy, or mitochondrial disease, which we certainly have some of the pioneers and the world leaders in this area, which really got me interested in the whole area. And we heard earlier about Kearns-Sayre syndrome. This is actually a patient with Kearns-Sayre syndrome, and you can see the impairment of eye movement when she looks right and left, and the ptosis, which was shown earlier. So what we've done is we spent a lot of time looking at sticking needles in people's legs, AV catheters, to understand the molecular adaptations and start applying them back to our patients to see if we could return these people back towards a more physiologic norm. And we've studied nutrition, which I'll talk about. We've done some drug studies, which I won't talk about, and we've done a lot with exercise. And I'm going to focus today on the treatment of more common disorders, which have atrophy and mitochondrial dysfunction, which is obesity and sarcopenia of aging. So when we look at what causes aging or sarcopenia, sarcopenia really just refers to the age-associated loss of muscle mass. There's a variety of things, and we already saw this first paper in the last talk, and more recently they've added two, including impaired autophagy and dysbiosis. But I won't go through all of these except to highlight a couple. One is that there is a whole area of aging research called inflammaging, where people feel that the chronic low-grade inflammation is important. And even inflammation can signal down and down-regulate mitochondria. But really, I'm a very mitochondrial-centric human being, and I'll show you in a minute, that I think much of what we see up here really can be explained by mitochondrial dysfunction. And that's why I feel it's important to target it. So with mitochondrial dysfunction, there's a variety of things that happen. If you don't have functional mitochondria, you attenuate muscle protein synthesis, which is energy dependent, and that can contribute to muscle loss. Mitochondrial dysfunction is associated with telomere shortening. We can get release of pro-apoptotic factors, can contribute to cellular senescence. We've heard several talks today talking about the increased ROS production, which can occur. It can be hormetic with exercise, or it can be deleterious if it's prolonged and sustained. This indeed can cause genotoxic damage due to the close proximity to mitochondrial DNA, which has very few intronic regions, and that is the whole vicious cycle, which was proposed by Harman to be one of the key factors in aging. And we've also, of course, heard earlier about inflammation link. We know that when we release danger-associated molecular patterns, naked mitochondrial DNA due to damage, we activate the NLRP3 inflammasome pathway, leading to inflammation. And all of these can interact together, and it's an extremely complicated system, but one that I think is targetable by focusing on the mitochondria. So sarcopenia is an important concept because if you get weak and you can't get off a toilet and you trip and fall and break your hip, you're going to be institutionalized. So sarcopenia, as I mentioned, is paucity of flesh. It's muscle atrophy or weakness, which is more than 2 standard deviations below the norm. And as I mentioned, it's important because there's a strong relationship between thin, skinny muscles and poor function. Getting off of a toilet, for example, leads to functional impairment and eventually higher costs. If you can't get off a toilet, you need a personal assistant to come in, you need adaptations to your bathroom, etc., and it increases the cost. 10% of those over the age of 70 and 30% of those over the age of 80 have functionally limiting sarcopenia in North America. And that's an issue because this is a map of the proportion of those who are over the age of 65 in the United States. Many years ago when my youngest daughter was born, 2015, and fast forward to 2025. And you can see that the proportion of older adults is increasing significantly. So this is an important health care issue that we have to deal with because we are getting this huge, massive increase in older adults with the coexisting functional impairments, which are going to strain the healthcare system. But of course, the other similar trend is obesity. Currently, 2/3 of those in the United States are overweight or obese. This is happening in all countries. It's estimated that 1 billion people currently in the world are obese, and this, of course, shortens lifespan and health span. And again, this is the United States, very similar to what we showed with aging, increased proportion of those who are overweight or obese. And of course, we know that with obesity, all of the other comorbidities which influence health span and lifespan go up. Fatty liver disease, which is the new hepatitis, cancers, for example, breast cancer, even some of the colorectal cancers, and of course, cardiovascular disease. So is there a relationship between low muscle mass and obesity and mortality? Everyone pretty much knows that obesity is associated with higher mortality, but low muscle mass is as well. So it's really important to think of obesity and muscle mass in the same discussion topic. So with obesity, again, as we go to higher quartiles of obesity, there is an age-adjusted increase in younger and older individuals in all-cause mortality. No surprise to anyone. I think what people probably didn't realize is muscle mass is also important. Those who have the lowest quartile of muscle mass have higher morbidity. And it makes sense. If you're weak and you trip and stumble, break your hip, etc. So you can see here those in the lowest quartile, and I won't go through all of them here, but to suffice to say, if your muscles are skinny and weak, you increase mortality. So it's important to both try and lower body fat and improve muscle function. So some of the things that are associated with mortality, obviously everyone knows all of this: cancer, cardiovascular disease, COPD, respiratory disorders, falls and accidents, we talked about that, obesity. all of these are reduced with regular exercise. So if you look at this, you say, well, if exercise can improve all of these, does it improve lifespan? So most of the evidence, the only evidence we have that we can increase human lifespan is endurance exercise. So endurance exercise is exercise where you're doing longer duration, lower intensity, and this leads to mitochondrial biogenesis. We and others have shown you can double your mitochondrial mass in your skeletal muscle after 3 months of regular endurance exercise. And when you look back on all of the epidemiology about lifespan, it's all based on more regular endurance type of activity. So this is one of the studies I wanted to throw in because it was from Northern California, out of San Francisco. Interesting study, you should take a look at it. That's the reference here. So what they did is they looked at a number of runners, and then they had either their partners or colleagues who were age and sex matched. And these individuals were 50 years or older, and they looked at the 21-year follow-up. And what they found is that the runners versus the non-runners showed lower risk of cancer, neurologic disease, and cardiovascular disease. And when you look at some of these, you might say, well, cardiovascular disease makes sense, but things like cancer and other neurologic disease like Alzheimer's, Parkinson's, et cetera, clearly implying that there are myokines, we call them exerkines, which are mediating these systemic benefits. But let's look at mortality. So this is the mortality risk in the runners. 15% of those at cohort inception had died over the ensuing 21 years. And for the sedentary individuals, 34%. So one of the first studies to show that running is good for you and it'll save your life and give you a longer life. But what are some of the other benefits of regular endurance exercise? If you want to read, the top person in the world who's done most of this is Stephen Blair. And this is a summary, a meta-analysis of many, many studies just conceptualized here. So this is the relative risk of disease X, Y, or Z, one being no different. But you can see all-cause mortality here in black goes down as we increase the hours of vigorous physical activity. So again, 3 hours, you're going to reduce, probably the majority, almost 70% of the net benefit you're going to see is with only 3 hours of vigorous physical activity. But look at some of these other disorders which are lower in those who do more regular physical activity. And you can see that it's a multi-systemic benefit. And I don't have time to get into it, but really that's another area of our research is what's mediating this multi-systemic benefit. And indeed, it is exerkines. Step count. Does anyone know what about 2 weeks ago they did to the recommended step count? Did they increase it or decrease it? Decrease to what? 7,000. Pathetic. It's pathetic for this reason. I mean, just take a look here. So this is the relative risk of all-cause mortality. This is the old guideline, 10,000 steps. You can see how there's a pretty significant reduction in all-cause mortality and even cardiovascular mortality. So the problem is if you step it back to 7,000, you say, well, it's not a huge difference. But what do most people do? Did everybody here get 10,000 steps 3 weeks ago? No. Many of you are shaking your head no. So we strive for the goal, but most people don't achieve the goal. So we now put it at 7,000. We're going to strive for it. We're going to go back to the average North American step count. What's the average North American step count? 4,000 steps. So again, we go down to mediocrity and to being lazy, and we're going to end up with higher cardiovascular mortality. So again, step count is important, getting on the same theme. Now, we also know that being fit is more important than being fat. And that is an important concept that came from Stephen Blair. And this is just one of many studies that shows that if you look, for example, at those who are normal weight, this is, again, about the 4 to 5 year lifespan extension for those who are normal weight versus those who are, sorry, these are normal weight individuals, my apology. These are the inactive versus active. So that's about the 5 year lifespan extension. But as we increase the levels of obesity, and this is based on BMI, which we won't have time to talk about, you can see that you still get a benefit from exercise. But his overall take, which I agree with, is fitness is more important than fatness. So if you are overweight, don't focus so much on the scale. Just get out there and do something. It's still going to be good for you. So let's turn to weight training because all we've talked about is mitochondria. AMP kinase activation, let's turn on those mitochondria. But we forget that it's important to have muscle mass. So there's this AMP kinase, mTOR. mTOR is bad, take rapamycin, get rid of your mTOR. But our bodies go back and forth between AMP kinase activation, fasting, exercise, and mTOR rebuilding. And so weight training, building muscle, is essentially an mTOR stimulus. So this is a summary of some of the work. These are just a few of the papers we've published over the years, just to give you a bottom line, which many other people have shown, what happens when we do resistance training. So if you do exercise training, and again, we've done studies 3, 4, 6 months, both men and women. We always have equal numbers of men and women, even up to age 92, 2 to 3 times per week, and I won't get into this. But what we see, of course, increased strength, lean body mass, muscle fiber area. Importantly, that correlates to functional improvement. Going up 4 stairs, getting out of a chair, etc. When I started this work 20 years ago, people said, Mark, you're crazy, you're going to hurt older adults. And the Europeans didn't even like doing this research. They said, well, Mark, of course, everyone's going to increase oxidative stress, cause more damage. No, Johnny Parisi, one of my first grad students, clearly showed that we lower oxidative stress with regular exercise. And the reason for that is that we increase antioxidant enzyme abundance. So that chronic oxidative stress is actually lower. And that's been well shown by our group. We increase mitochondrial enzyme activity in older adults. We generally think that mitochondria only go up with endurance exercise, but in older adults, the stimulus is sufficient to increase mitochondria. We decrease inflammatory pathways, but there's no beneficial effect on body fat. So many people are turning to things like intermittent fasting and the easy route out, GLP-1 agonists. So this is my life in a nutshell. I see patients with a variety of neuromuscular and neurometabolic and neurogenetic disorders. Hard to get money in the area, so we've studied aging and obesity where we can get money from CIHR and NIH to study things. And our main group that we see in the clinic are patients with a genetic mitochondrial disease. So we know that these consequences occur when mitochondria don't work. We know that all of these converge on the mitochondria to cause issues. All of you who are aging, if you're over the age of 60, you're going to start seeing these cytochrome C oxidase negative fibers, dysmorphic mitochondria, and all of these processes are going on as we age, but they're just accelerated in all of the disorders that we see. So we started to wonder, could we use the multi-ingredient supplement approach to try and provide some benefit to our patients? I should say that Tanya Tabasalo, a good friend and colleague, has shown clearly that exercise, both endurance and resistance, helps our mitochondrial patients, but I don't have time to get into that. So what are mitochondrial disorders? Very briefly, these are disorders that traditionally affect the electron transport chain, lead to decreased ATP. We know the mitochondria have many other factors, and there's a variety of other mutations which affect other issues. But that was really kind of where the field was when it first started. So the field started back in the late 1980s, where deletions were found in people with this Kern-Sayer syndrome, which are usually sporadically occurring. Doug Wallace discovered a point mutation. When we have these numbers here, that's the point where the transition mutation occurs on the mitochondrial DNA in the 16.5 kilobases. So Doug described this point mutation here for Leber hereditary optic neuropathy, mitochondrial encephalopathy, lactic acid and stroke-like episodes. Massimo Zeviani and others discovered a point mutation here, and that led to significant issues with mitochondrial energy transduction, resulting in phenotypes which are generally presenting to neurology, which is why we as neurologists tend to see these folks. And the reason why is that we know there's mitochondria in every cell in our body except for mature red blood cells, and those that are terminally differentiated and rely heavily on aerobic metabolism, like the brain, are more susceptible. So we often see things like spastic paraparesis, optic atrophy, high-frequency sensory neural hearing loss, a lot of neurology issues. In muscle, of course, we can see either exercise intolerance. In fact, in our MELAS patients, the VO2 max on average in the patients in one of our first studies was under 10 milliliters per kilogram per minute. Why that's relevant is they estimate you need 12 milliliters per kilogram per minute for independent living in older adults. So trying to increase your VO2 max, which you'll see is an important metric that we look at. And there's a variety of other tissues, but I'm not giving a mitochondrial disease talk. So Why is that relevant? These are the patients that I see. So what are we going to do? How can we treat these individuals? Well, the late Flint Beal and I put forward a hypothesis that to treat neurologic disease, we have to target the multiple final common pathways, and we've heard of them today: impaired autophagy, oxidative stress, mitochondrial dysfunction, excitotoxicity. So a single agent is unlikely to be as effective as agents which target the multiple final common pathways. So I tried for 6 years to the United Mitochondrial Disease Foundation to bring forward a cocktail. I was rejected multiple times, and I quoted all sorts of good evidence. One of them, for example, is chemotherapy. If we look at acute lymphoblastic leukemia, 30 years ago, our success rate was around 40% 5-year survival rate. When they came up with the 4 plus the intrathecal methotrexate therapy, the combination therapy, survival rates skyrocketed. Now over 95% of kids are surviving. We also put in a grant based on our MDX. This is a muscular dystrophy mouse model where we used multiple final common pathway approaches with nutraceuticals and the standard of care cortisone, and doubled the benefits of the FDA-approved drug called cortisone. But in spite of all of that, in mitochondrial disease, we were rejected by the UMDF because they wanted a cure. So with my own money, out of my own pocket, I did this study to prove it. So you can see Flint Beal was here. So we published this a few years ago. We did 2 months on, 2-month washout crossover study using coenzyme Q10, alpha-lipoic acid, vitamin E, and creatine monohydrate. And we'll get into the rationale, but it's probably self-evident for all of you smart people here why we chose those. We had 16 patients with genetically confirmed mitochondrial disease. And what we showed, and it was important because some people were leery of the fact that regular ubiquinone or CoQ10 could be absorbed, and of course the plasma concentrations went up. We used 8-hydroxy-2-deoxyguanosine as a marker of DNA damage, and that went down. Lactate went down, which is a surrogate for improved mitochondrial function, and 8-isoprostanes, a marker of lipid peroxidation, went down as well. So everyone criticized me and said, well, Mark, you know, it's the CoQ10. You've got to choose one agent. It's just decerebrate for you to have multiple ingredient supplements, even though that was our hypothesis. So again, nobody would fund it, and so I had to use my own money again. Again, all before we started a company, right out of my pocket, out of my retirement fund. So we did a study, 2 months, similar, 2 months on, washout, 2 months on the placebo, and vice versa. All RCT, all done under GCP. We used super high doses of CoQ10, 600 milligrams BID. 30 patients now, so we really ramped it up to make sure that we wouldn't get a false negative result or a false positive. And we did spectroscopy, which cost me a fortune, cycloergometry, and what did we show? Nothing at all. So again, proving that the multi-ingredient approach is probably reasonable, and we can debate later why we think that this didn't work. So when you think about multi-ingredients, we've talked about the fact that I think it's important to have multiple nutraceuticals and or drugs that target the final common pathways. We talked about the targets. But again, this is common in other common disorders like obesity and aging, and we're going to talk about that. So if we think about older adults, we've already said why it's important to increase muscle, and also decreasing body fat is critical with the obesity epidemic that's going on. So what are the drugs that we have that are most popular? Ozempic is the first one. Of course, it's a GLP-1 agonist, so it tells your brain to stop eating, tells your gut to stop moving. And Lilly, of course, is battling with Novo Nordisk. They've come out with one that's a GIP-1 GIP dual agonist. What the issue is with these drugs, which I pointed out and nobody believed me in 2021, is there's a loss of lean body mass. Why did they bury it? In the main body, it says that body composition improves. For everyone here, you think, well, muscle's probably at least good, maybe even better. But what they did is they looked at the ratio, and you lose a little bit more fat than muscle, but you'll see that it was buried. And in fact, 41% of the total weight loss with the seminal study in the New England Journal is actually lean body mass with Ozempic, and 24% with the dual agonist. So The other concept, that's one, preserving muscle while we lose body fat, which is going to get into my final bit. The other one that is important is when we're giving multi-ingredient supplements, like I just showed you in our mitochondrial patients. I am a huge proponent of exercise. It's been shown to be beneficial in our patients. We published a good paper in myotonic muscular dystrophy type 1, aging, etc. So I would be very leery of any supplement superimposed on exercise which would blunt the benefits. And therefore, why am I thinking about this? It came from this paper, and there's many other papers to support it. So that's the paper down here in PNAS. What they did is they gave antioxidants, vitamin C and E, to untrained individuals before an endurance exercise program. And what they said is, well, did the classic adaptations occur? And what they found is that when they had the supplement, it blunted the improvement in insulin sensitivity. So they got no benefit from doing 3 months of endurance exercise training. And adiponectin is actually a cytokine that's beneficial and has pro-metabolic effects. So that was completely blunted. And the rationale here actually was one of Bruce Spiegelman's, Julie Saint-Pierre, who actually mapped this out, that the free radicals can signal through to upregulate PGC1 alpha. So if we completely suppress free radical signaling during an hormetic response like exercise, we can blunt the beneficial effects, at least through PGC1 alpha. So we have to be careful, and that's why all of the things we test, we always do it with exercise to make sure we're not having a blunting effect. So we'll turn now to the final bit of what we've actually done. So one of the things that we were interested in is, could we take our mitochondrial enhancer and have a beneficial effect on obesity? So what we used was the high-fat fed mouse model. So this is a high-fat fed mouse. This is a chow-fed mouse. And after just 30 days, you can really see, and you'll see in my graph in a minute, the difference in the mice. So what we did is we did exercise as one intervention, because that's the Mother Nature's gold standard for beneficial effects. And then what we did is I wanted to test my mito enhancer. My theory was that my core here of mitochondria, plus we had creatine in there, which I'll talk about in a minute. And then we also added beetroot because they contain nitrates, which actually do have an improvement in mitochondrial efficiency. Then we scanned the literature and found what are the weight loss supplements which have the best support. Green tea, good support, green coffee bean extract, forskolin, and the other one that I didn't have listed here is conjugated linoleic acid. So what we did, and the reason why we got the patent, is we did 5 + 5, 10, 7, 9, 8, all the different combinations, and you'll see what happened. So these are chow-fed animals over the 1 month duration. All of the animals received high fat, and they continued on high fat throughout the duration of the experiment. And what we have here is the control group who continued to get high fat. In mauve here is exercise. Of course, it's beneficial. This turns out to be those 7 ingredients I just showed you. And there's a whole bunch of ones in here, but I pulled them out because it was complex. Nothing was as good as these 7. So we did 5, 5, 10, 9, 8, and 7 turned out to be the best. What was most exciting is that I was very worried that we were not going to be able to move forward if I blunted the benefits of exercise. But we had animals on the supplement plus exercising, and it was actually synergistic. So they even did better when they exercised. So there definitely was no blunting, so we decided to move ahead. But we wanted to look at the mechanism. We heard earlier about Bruce Spiegelman, who discovered PGC1 alpha, the master regulator of mitochondrial biogenesis. You can see it's lower in high fat. And before Health Canada made us change the name from metabolic enhancer, we had a variety of different combinations, which I told you about. This ME3 moving forward is going to be what we call Trim 7, because that's what Health Canada let us use, and they wouldn't let us use metabolic enhancer. So this, you'll see in a minute, became what we commercialized, this metabolic enhancer. Again, very similar to benefits with exercise, but exercise is always additive and beneficial. So this is a subunit of the 4th respiratory complex, cytochrome C oxidase, again going up, and of course suppressed with the high-fat diet. And then we talked about inflammation. We heard the nice link between the PGC1 alpha and inflammation. So lower inflammation with all of our different strategies, including exercise. Again, early on, people who weren't thinking about it thought somehow exercise is going to give you chronic inflammation. It definitely does not. And then downstream, we mentioned before about the NLRP3 pathway, eventually IL-1 beta and IL-18, so caspase 1, again, lower. So this is CPT2. CPT2 is carnitine palmitoyl transferase 2. You mentioned CPT1. And this, of course, is important in fat oxidation and importing long-chain fats into the mitochondria. Here, and hormone-sensitive lipase, which is the lipase which breaks down your intramyocellular triglycerides, again, was higher. And this is why, ultimately, we chose those 7 ingredients. And I have no clue why this happened, but for some crazy reason, we pulled out a bunch of stuff, and it turns out that this essential 7, so this really is our trim 7, increased UCP1. So UCP1 is uncoupling protein 1, and we didn't just cheat and use mRNA. This is protein, and you can see how much higher it was here. And that's part of the reason why we stuck, not only the functional metrics were better, but at the mechanistic level, when we looked at the various fat pads, we pulled out 4 different fat pads, and this was consistently upregulated. One of my buddies didn't believe me. I was presenting at a talk, and he said, "Oh, you're full of crap." He's a fatty liver guy, Rick Austin. So we sent him the diet blinded. So Rick Austin, this is the publication here, did a study, and he's a big lipid guy. So he's got these mice that are PCSK9 knockouts. So with knocking out PCSK9, they get massive fatty liver because they pull all of the LDLs into the liver. And we completely protected with the supplement, reduced body fat, just like we showed, lowered PCSK9 levels, and reduced LDL cholesterol. This is the fat in Rick's hands on high fat, and that's the same high fat fed animals on what we're now calling trim 7. And this is the liver. So you can see the huge increase here in fatty liver disease, which is a huge issue now, and there's no approved treatment for fatty liver disease. Some of the GLP-1s definitely show a reduction in the markers, and this is with the metabolic enhancer. So, of course, I don't believe anything in worms, Petri dishes, or anything. Great for mechanism, but show me a human study. Make sure it's done under GCP and data locked, the whole bit, which this was. So what we did is one of my postdocs, Josh Netterveen, supervised a study with 60 overweight and obese men and women. They had 3 months on the supplement versus placebo. As per FDA and Health Canada, we had to use weight loss as our outcome, but we're much more interested in this body composition index. The paper's coming. We've got a new concept that we're putting forward called the BCI, which is your lean body mass divided by your BMI, which correlates much better with body fat, and we don't falsely call people obese when they're not. And the flip side, people who are obese but actually appear to be lean, many of our patients are actually appropriately categorized with this new BCI that we're going to be publishing soon. So what did we get? This is the trim 7 group. More of the people lost weight versus those on the placebo. Very real world study. So we just said, you know, here's the pills, here's the Canada Food Guideline, and here's the CSEP, Canadian Exercise Physiology Guidelines for Exercise. Bye-bye, we'll see you. So very real world, and you can see here, even though it was an RCT, a significant reduction. But importantly, as we predicted from what we saw and what Rick saw, there was a reduction equivalent to what you see with Ozempic in the reduction in fatty liver markers. ALT and AST were both down significantly. But importantly, unlike what I'm going to show you in a minute, the significant loss of muscle mass, there was no loss of muscle using proper DEXA scans in these individuals. So then the flip side, as I was mentioning before, activating mitochondria, we also have to rebuild. So what we do find, and this is work that Stu and I and others have done over the years, when we think about rebuilding, regrowing, activating mTOR, of course, providing exogenous protein is important. What do we know about protein with older adults? We know that they're very resistant to the beneficial effects. If I take a young person, I give you, X amount of protein, you're going to get a big increase in protein synthesis, and that is blunted with older adults. As a consequence, Stu has proposed that older adults should be taking in about 50% more than the US RDA in protein. High biological value, we talked about that before, because if you have higher biological value, more can be incorporated into meat. Most older adults, especially institutionalized, like to skip breakfast, or they have low biological value food, tea and toasters, you've probably heard of that. And so the best way to stimulate protein synthesis is to have 20 grams of protein with each meal, and generally taking protein after activity is more efficient. So if you've just finished activity, you have a window of about an hour where the amino acid transporters will pull in more protein. So timing is also a factor to consider. So Stu did a study, and this is where our company started. We actually bought the patent based on this, where he took all of the research that he and others have done, put it into a multi-ingredient supplement to help older adults increase lean body mass. So what Stu and Johnny came up with was whey plus casein plus vitamin D, creatine, fish oil. Now, again, what they did, which I don't agree with, and you'll see in a minute, they used a carbohydrate placebo. Kind of cheating. But they did show increased strength, lean body mass, composite cognition, lower triglycerides. So we actually bought the patent off of them, and I used my humanized milk ratio, but we didn't cheat. We went against collagen. So we had isoenergetic collagen, quote unquote, placebo, because there's a huge increase in the interest in collagen, especially these collagen polypeptides. There's a whole company that has a dude doing a one-arm push-up saying how great this is, and it's going to be great for older adults. So if you've already bought some, wait till you see the results. So what we found is that lean body mass, lean body to fat ratio, strength, and even functional metrics were better in these older adults up to age 92 who trained on the combination versus collagen placebo. The problem, though, with aging is that even higher proportion are obese, and that's called sarcopenic obesity. And I won't go through the whole vicious cycle here, but as you become more disabled with pain, weakness, you don't move as much, you tend to relatively eat more, and you end up with a greater amount of adipose tissue. So one of the things that we wanted to do is to take a look, and this was a retrospective look at the study that I just told you about before, with this muscle 5 being superior to collagen peptides. And we wanted to look at those who were eligible for Ozempic. So overweight plus one metabolic risk factor or obese. Let's go back and take a look and see, could this be something reasonable? Because all of the interest now that the genie's out of the bag is, oh, take our protein, it's going to protect you against the deleterious effects. So this I saw just last week when I was ordering my Nespresso cups. This is what Nestle has done. So Nestle is using collagen. They're promoting collagen to attenuate the deleterious effects of muscle loss. Now, what we do know is, of course, we knew we were going to get muscle loss with GLP-1s because with bariatric surgery or even decreasing your caloric intake by 500 calories, you lose bone and muscle. So I guess they think that it's going to somehow help. So what we did is we looked at our folks who were on our supplement versus collagen, and what you can see here, one of the things is that this is their voluntary energy intake. It was not increased at all, but with the collagen, they actually increased the amount. So in this study and another one that we've done recently, the increase in GLP-1 and GIP with that humanized milk ratio attenuated this increase in in energy consumption. But what do you see here? This is total lean mass. These are the non-obese individuals. We already published that it was more superior with our combination versus collagen. But in the obese subgroup here, you can see that they actually lost total lean mass versus the combination. This is appendicular skeletal mass, your arms and your legs. This is fat mass, which is interesting. And you can see they actually continued to gain fat in spite of spending 3 months with supervised exercise training. They gain more fat. And this we're calling not just the anabolic resistance, but a metabolic resistance, which happens once you become overweight and obese. Very hard to overcome, but you can see that there was some success here, certainly versus the collagen, probably because of the suppressive effects on appetite, which happen with the combination. And then, of course, we looked at leg strength. Again, they actually got even weaker in spite of training for 3 months on the collagen. Functional testing, 5 times sit to stand, 4 stair climb, and timed get up and go. All of these important things that we use in aging research to predict functional impairment were more favorably enhanced. And I won't spend too much time on this, but hemoglobin A1C was better, total cholesterol was better, LDL better, and even inflammation was a bit lower. So we'll finish finally very briefly because something just came out from Lilly as I was listening to one of the talks earlier, which is relevant. And this is the semaglutide study. So again, semaglutide, this is the New England Journal of Medicine article. GLP-1 agonist tells your brain to stop eating, people lose weight. So placebo versus semaglutide, wow, second coming of Christ. This is unbelievable. Body composition's better. But everyone here, do you always go into the supplemental data? If you do, you would find this. So deep in the supplemental, they buried what's most important, which is the DEXA scan. Also, what's a DEXA scan for? Bone. They pulled the bone data out. No bone data, which is criminal. It's going to be the biggest litigation in the history of mankind in 10 years when people are breaking bones. You'll see. Mark my words. So what you see, of course, you lose more fat on semaglutide, but look at the lean body mass. It's dramatic. The lean body mass is mostly muscle, but also they pulled the bone data out, so we can't find it. I asked them for it, and they won't give it to us. So is there any way to attenuate this? And this is all the hype, and you'll see this everywhere. So Lilly and Novo Nordisk are saying, don't worry about it. Who cares? Overall, you're doing fine. Don't worry about it. The challenge is, once you've lost lean body mass and bone, it's very hard to regain. We heard about menopause. A woman in menopause, if you lose bone, there's no way you're getting it back. Maybe if you go on some estrogen replacement, but it's very, very, very difficult. And what's easier to gain back? Fat or muscle? Fat, of course. 50% of the people on these medications stop after a year. So then you do 3 or 4 cycles, you're going to be a boneless chicken farm. So it's a big issue. But they're saying, don't worry about it. Just exercise and do a higher protein. So this is their solution, and Nestle's jumped on it. They've got their collagen there. After you see this, I don't know if you want to use the collagen, but maybe you do. So that's what they're suggesting. But the other thing is they're all in on myostatin inhibitors. I won't get too much into it, but this is all the rage for Lilly. In fact, they hired a vice president from another company who was big on these, and they've got studies on this bimagrumab. So this is a monoclonal antibody which acts on activin 2B receptors, which is the myostatin. So it removes the brake on muscle growth, and people have shown minimal increases in muscle mass in older adults, but they're all in on this. So what happened about 2 hours ago is the announcement was made that they've stopped these for, what did they call it? Business reasons. So either there was a side effect or it didn't work. So that, as of this morning, has now gone, and other people are looking at other different interventions. But will exercise work? So this is a study which leads me to believe that I don't think just exercise and standard protein is going to be helpful. So again, a high-quality study in New England Journal of Medicine. They had obese individuals over 65, men and women, and what they did is they randomized them to a energy restriction with endurance resistance or combination. But what's interesting is that they gave them lots of calcium, lots of vitamin D, high protein, counseled by a nutritionist to increase their protein intake, and they went on a caloric deficit. So what did they show? Decrease in body fat, as you would expect. Not quite as extreme as you see with the GLP-1s, but significant loss, very similar between the groups. But more importantly, why I'm not sure that just taking a little bit of extra protein without all the nuances is going to make a difference. This is bone mineral density. So it actually got worse with the aerobic group, and even with resistance and combination exercise, bone mineral density went down. So what do you think is going to happen with tirzepatide or with semaglutide? It's got to go down. And in fact, there's a study that came out showing that it did. This is lean body mass. Again, in spite of weight training, and endurance exercise, it wasn't sufficient to attenuate the weight loss-induced loss of lean body mass. So I really don't think that with more extreme things like we're seeing with tirzepatide, with almost 20% loss, that that's going to be sufficient. So what are some of the other things? Maybe what I'll do is we'll leave this for our discussion later. I'll just go through all of these. I've got 1 minute left. Look at that. But this was I just added this morning because it came across my my inbox. So Lilly spent 1.3 billion on bimagrumab. Bimagrumab, I did an estimate. At current prices, it's about 1.3 million per person per year. It's an intravenous infusion every 2 weeks, and that's what they went with. There was no effect of strength in an aging study, and even the conclusion of the aging study that was published a few years ago was drugs that increase muscle mass without improving strength and function are unlikely to be of any clinical relevance. But this morning, Lilly ended studies for strategic business reasons. So anyhow, that one's gone. And then finally, this is what I would suggest. We're all going to be dead before we know if anything's going to extend lifespan or health span. Everyone in here is going to be dead before we get the answer. So therefore, we have to rely on metrics which are correlated with death and health span. And the metrics I would suggest in studies is we have to have some impact on obesity. We have to have favorable effects on lean body mass. We have to improve function, because if we increase strength but we don't improve function, like who cares at the end of the day? Because that's what causes disability. Aerobic capacity strongly correlated with functional capacity and strongly correlated with increase in health span and lifespan. Functional capacity tests that are very relevant to your day-to-day activities. So at the end of the day, we're never going to know if rapamycin or any of these things are going to, well, rapamycin's garbage, but we'll talk about that later. They're not going to extend lifespan in humans. So we're going to have to look at these metrics, and as many of these we can favorably enhance, I think are going to have a good kick at the can to improve lifespan and health span. So with that, I'll finish with all of my grad students, the clinic, Bob Navio in particular, collaborators locally and internationally, and all the folks that funded this. Thanks.
Stay tuned for the second annual symposium on mitochondrial health, health span, and aging.